Thank you. Good evening, and thank you for the invitation to speak today on NAPRC for rectal cancer, the new standard. I have no disclosures. So oftentimes we think of standards and accreditation in opposition to kind of freedom, flexibility, and individual care. But what we should really be thinking about it is more like a balance. So not a fight, but a balance. So a standard provides requirements, specifications, guidelines, or characteristics that can be used consistently to ensure that materials, products, processes, and services are fit for their purpose. And so what is the purpose of NAPRC? So NAPRC was developed as a collaboration between the Ostrich Consortium, which stands for Optimizing the Surgical Treatment of Rectal Cancer, and the Committee on Cancer of the American College of Surgeons. And so its goal really primarily was to ensure that patients with rectal cancer care were getting the appropriate multidisciplinary approach. And it really has 4 pillars, which include program structure, patient care processes, performance improvement, and performance measures. And so what is an antithesis to the standard? Well, variation. And so in this study in DCR, looked at hospital discharge data in 21 states, which had county level place of residence, included almost 20,000 proctectomies. 50% of the cases were APRs, and as you can see, only 20% of counties had a colostomy rate that less than 40%. So this is an illustration of the variation in stoma rates in New York by county. And so it's not just New York, this is just illustrated for purposes, but every state had variations based on county. And so what that meant was that depending on which county you lived and where you got your care, the probability of you getting a permanent stoma either increased or decreased just based on where you lived. And so we don't do as good of a job as we think we do. So this is a National Cancer Database study of stage 2 and 3 rectal cancer patients. And what they wanted to see is the level of neoadjuvant therapy for appropriate patients. And what they found was significant variations in the level of neoadjuvant therapy that these patients got. And it was based on the type of cancer center that it was, some geography, some patient demographics. And what they also found is that the majority of patients got their treatment in low or intermediate volume centers, whereas it was the higher volume centers that had higher adherence to these evidence-based cancer care standards. This study also was a National Cancer Database study, and it looked at positive circumferential margins. And so they were trying to find factors that were associated with a positive margin. And so they did find, kind of your typical tumor factors related to positive margins. So T3 or 4 status, high grade, LVI, neural invasion. But then they also found other things like geography. So geography was associated with whether you ended up with a positive circumferential margin. And at least in this cohort, 17% of patients had a positive margin. And so what we need to ask ourselves is, as a community of professionals, are we okay with a positive margin 17% of the time? And so I hope that the answer is no. So we'll kind of go through some examples. So this is a map of Western Europe, and in the early 1990s, this study came out, and it showed that rectal cancer care outcomes had improved over the years in 5 Nordic countries. But the improvement actually wasn't as great in this country, Denmark. And subsequent studies also kind of confirmed that patients in Denmark did not have as good outcomes in terms of getting rectal cancer care treated as the other 5 Nordic countries. And so this essentially was a wake-up call for them. And so they went on to do a few things. So in 1994, they established the Danish Colorectal Cancer Group. At that time, also TME, they introduced TME and established it as the gold standard. They published guidelines in 1998 of what constituted appropriate rectal cancer care. And in 2000, the National Cancer Health Plan kind of came out with guidelines of increasing diagnostic availability for diagnostic studies, and that they changed their rules that anybody over the age of 40 who had clinical suspicion of rectal cancer could undergo a flexible sigmoidoscopy or a colonoscopy as opposed to a double contrast enema. And by 2001, they introduced preoperative radiation and multidisciplinary teams were established. And in 2004, what they noticed was that the number of places that were treating rectal cancer had begun to decrease. And by 2004, that had decreased to about 50%. And so what had happened was that as the requirements were established, only the places that could meet those requirements were still treating rectal cancer patients. And so what they saw was an improvement in 5-year survival over that time period. And so by the end, their rectal cancer outcomes were equivalent to those of the other 5 Nordic countries that they had previously lagged behind. And in this study where they looked at that, it was over 10,000 patients, and they saw an overall improvement in their 5-year rectal cancer outcomes, 9% for stage 2 and 20% for stage 3. What was also interesting was that men disproportionately had that improvement versus women, and that is something that they said they were going to look into. But overall, they did have improvement with these measures. So it wasn't just one thing that they did. It was a collaborative effort across the country to improve their rectal cancer care. And so the Commission on Cancer NAPRC program was kind of established to help address this variation in rectal cancer care in the United States. And so this is one of the standards that the facility must have a defined rectal cancer multidisciplinary team, and that includes members from surgery, pathology, radiology, medical oncology, and radiation oncology, as well as have a rectal cancer coordinator, which not only tracks quality metrics, but also helps the patient navigate through the whole process. Part of the standards is also a TME evaluation. So the surgical specimen gets photographed, and then you get to evaluate the quality of your TME. And so I could look at my TMEs weekly and say, maybe because I'm right-handed, I cone in a lot on the left, and doing this consistently in a kind of and have peers comment on your TME is a very helpful way of improving your technical skills. And so could reviewing your TME on a regular basis improve your technical skills later on. And it really isn't a punitive process. It really is about the learning process and getting feedback about your surgical specimen. Synoptic reports are also an important part of the process, and so there's synoptic reports for your operative note, for radiology as well as pathology, because multiple studies have found that key information gets transmitted better in synoptic reports versus a narrative form report. And then there's a couple other standards that are part of the NAPRC. However, I would say that probably one of my favorites is that I think it improves, that by adhering to these standards, it really does improve communication. Not only communication between the hospital member, the treating people in the hospital, but also your referring physicians, because there is a requirement for a pre and post summary, a pre and post summary of treatment. And so you may be asking, well, don't we do all this already? Don't we work together as a multidisciplinary team? Don't we communicate, et cetera? So this publication in 2019 by Swords was a retrospective study, and it focused on a large hospital in the Intermountain group. And what they found was that local staging, like whether a patient got locally staged, was highly variable. So if you see there, surgeon 1 only locally staged their patient a little over 50% of the time. Surgeon 21, almost 90% of the time. So in this patient cohort, 43 of the 240 patients had no local staging for their rectal cancer. So a whopping 17.9% of patients had no preoperative staging. And so maybe they had a good reason. So maybe they had a good reason for not doing the staging. So let's see. So it looked like the majority of them just went to the operating room and didn't document a reason for not having local staging. The second group, the surgeon did not confirm that, in fact, it was a rectal cancer versus a colon cancer. And so before we start judging this group, I think it's probably one of the few kind of brave groups that has really examined their data and published it. And so this group, Richardson, they wanted to see, well, does having an MDT really have an effect on short-term oncologic outcomes? And so they did a retrospective review and collected data before and after implementation of their MDT for rectal cancer. And the light blue is before the MDT, the dark blue is the first year, and then the aqua is the second year. And so they did find overall improvement in their short-term oncologic outcomes. And what was interesting, it was their technical outcomes. So if you see here, persistent distal cancer, distal tumor, that was much improved when they implemented the MDT. This group also wanted to see if having an MDT did anything. And so they documented a change in plan in 26% of patients that were presented. And that was, it didn't matter whether the surgeon had less than 10 years in practice, 10 to 20 years in practice, or a very experienced surgeon of more than 20 years in practice. They each had cases, so 23, 28, and 26%, where their clinical plan, their management plan changed based on MDT recommendations. And so in summary, standards give us a common language for common processes and for consistent results. And rectal cancer care is complicated, and so the NAPRC really gives us a structure to put these standards to work. So thank you.